Okay, Representative Bacala, is it for this group or the next? Sure.
Real quick, guys. One of the things that we've noted, I think, when we talk about unspent budget authority, but you also have unique things that happen in the closed out year 17-18. There was a 13th payment made. Obviously, that was a one-time expenditure, not needed in the next year. What was the 13th payment amount? Do y'all know what that was? What is it?
That was the pushed payment that we
Right.
did.
Yeah,
So
we paid it all.
We
had enough money left over in 17 to pay it. What was that amount?
Oh,
You
hold on
have
a
it in
second.
your,
I have it.
in your,
We were able to pay most all of it. Hold on.
yeah, you had it in this thing.
I had it.
In the big thing that you printed out.
You get me in the ballpark. 133. That's good. We'll just stick with that. And if it's significantly more or less, I'll pick up on that later. Okay. That's just wanted to see if y'all had that. We'll come back after the presentation.
We have it
I'll
somewhere.
get you the exact number. Okay.
Okay. Okay, Representative Bacala.
Y'all knew I had a question. First of all, I want to go back to a question that I've been unable to get answered. Can you enlighten me a little bit on the people making $100,000 or more who enrolled in Medicaid?
Yes.
Okay.
Let me get to the right binder. So, do you want to be more specific? Because I have several answers. What do you?
Okay, how many?
So there were 1,672 individuals that were identified to us by the Department of Revenue who had income greater than $100,000 on their tax return in 2017, who were also covered by Medicaid. And so we've been working to review those cases and take appropriate action on each of those.
Okay, would appropriate action also be, have we tried to identify how we let these people sneak through the cracks and be enrolled with 100,000? Because you didn't find it, Department of Revenue found it.
Right. So the first thing that we did is take the information and and see if they were currently enrolled. We've been in consultation with CMS with regard to looking backwards. We do not have the authority to do that. We can take the information that's available today, whether it's historic or current, but we have to make a decision based on current information. So our focus was first to see how many of these individuals continue to be on the Medicaid, enrolled in Medicaid. And so the first thing we did was, of those 1,672, we found that there were 105 that were still enrolled that did have with wages in excess of the limit. And with those, we sent for requests for information, and there were 22 that remained eligible. They provided information that they were still eligible, and 81 of those were closed, and there are 2 that are still pending administrative
And
review.
just to reinforce that this is data that is 2 years old. We're talking about 2017 and it's 2019. And so people's life circumstances change. You know, they go through a divorce, they lose a job, they get sick and they're unable to work, and so on and so forth. And so it's important to understand also that we were following the agreement we had with the feds. We did not have, as we now have, which is a fix, the Workforce Commission data, nor do we have, which we're going to have next month, the tax data that we're able to then take into consideration when we're making real-time decisions. So although this was instructive, I don't want you to think that this is what the population looks like now.
Yeah,
And so that's what Jen's
and I'm going to
explaining.
just cut to the chase, because we did a multi-tiered. So the first thing we did is to see if we had wage data on them. If we did, that told us whether or not they were still eligible. If we did not, we asked them for information. Again, but the net result of that was that 229, or not quite 14%, remain eligible. There were about 12% that are still pending review. There's information that's pending or
Say
has
the
come
first
in.
number again.
So of the 1,672, 229 remain eligible. There were 677 that were not enrolled at the time of review, so there's nothing for us to act on. There were 555 closed, and there are another 211 that are still under review. So 40% were no longer enrolled.
40% no longer enrolled.
No longer enrolled.
60% currently enrolled.
No, sir. Well, the 14% remain eligible, so they're out of the way. Another 33% were closed, and then there are 12% percent, and I'm rounding up and down, but there's about 12% that are we're still reviewing the cases.
Okay. Now, that would be part of a larger Department of Revenue report. They ran a report on your population, I'm assuming. That wasn't the only thing they reported to you. Have they? That's just kind of the most egregious level, I think, right? What else have they prompted through that report? How many other reviews have they prompted? People making over 50,000 or whatever. And I'll ask just briefly if you don't
Right.
mind.
So there's a second set of information. This is we've received two sets. The first was over 100,000, and then more recently we've gotten a number of individuals who had income between 50 and 100,000. And I would emphasize that this is not a variance from their taxes and Medicaid application as was done in a previous analysis. This is simply they had between $50,000 and $100,000 reported on their taxes. There were 8,474 of those individuals. 3,550 were no longer actively enrolled in Medicaid as of this month. Another 924 were. 540 of those have current wage data that supports their ongoing eligibility, and there's another 4,384 that are being sent requests for information so that we can review those cases based on current income.
Okay, so I'm trying to tie this into the whole project we have kind of working together. The legislative auditor late last year identified 19,000 people who probably weren't eligible. More recently, you guys have identified 30,000 people who apparently weren't eligible. What is the overlap of those two? Are we talking now about 49,000 people or something less? I understand that maybe 2,000 was the overlap, so that 2,000 were in both groups, but I don't know if that's accurate or not.
So the auditor's office has not been willing to share their individual file with us, so we can't do a comparison.
I'm sorry, say it again.
We've not been able to get the individual file listing of who was on their analysis. We believe that there's substantial overlap. We did a similar analysis. Remember that theirs looked at 5 consecutive quarters of being over the limit. We looked at something similarly and came up with numbers that were substantially similar to theirs. But again, we've not received a person-specific listing of. And again, you're looking at different time frames, but nevertheless, we've not been able to do that comparison.
Well, maybe our auditor can answer that. Thank you. So anyway, I think, Jen, at a meeting outside of appropriations, you testified that you, generally speaking, y'all are finding about an 8% error rate when you do a survey, which matches what the auditor, I think, has done, about an 8% of groups surveyed.
I'm not sure.
Yeah, that was the number you gave us in the task force, that 8% was kind of the number of ineligibles.
That may be the PERM number that Representative Edmonds was referring to.
No. This was the 30,000 at that time was 37,000 people were identified amongst that expansion population, which represented, or whatever the population, which was 8%. Correct?
I know what you're talking about now. Yes.
Okay, so now I want to be clear that the 30,000 or the 37 that is now 30,000, or 37 is now 30,000. We have yet to survey the entire Medicaid population. Is that correct?
The wage data run in February was all adults,
Right.
so it's beyond expansion.
Right. So, and I do want to stress that was the entire population. So whereas in
the
the
entire
past
population of what?
of Medicaid expansion.
Of expansion,
Yeah.
that's right. I'm not talking about,
It was all adults, all Medicaid adults, beyond expansion.
But not children and pregnant women.
That's right.
Right.
But adults, we're just talking about adults.
Right.
but when you apply, when that 8%, when you use that number to come up with the initial 37,000, it would imply that you can kind of quantify that you have actually checked about 460 of 1.6 million applicants. How many cases have yet to be reviewed?
For the wage data?
No, for eligibility or wage eligibility or whatever.
So
I think
from an adult perspective, every adult was reviewed in the wage data in
How many
February.
adults are there then?
Somebody's going to have to pull it up for me. I don't know off the top of my head. We have about
462,000
700,000 kids, so I'd have to, somebody can look at it really quickly.
So maybe we've checked 462, I think's the number I saw somewhere, maybe 470.
But Yeah.
Okay, I'm not going to dwell upon it. We have yet to check the entire population, so we identified 30,000 just in a portion of the population.
But we do have for pregnant women and kids, they have ongoing eligibility. We don't take
Yeah.
their insurance away in the middle of a pregnancy.
I understand
So
the
we're not running
pregnancy.
this-
I think that there's also some issues with, what do you call it, the MOE?
Maintenance of effort. That's right.
Maintenance of effort, and I think that's been the reason that y'all have not surveyed the
Or children.
children. I did find a quote somewhere that said the MOE provisions do not prohibit states from making cuts to Medicaid or CHIP outside the eligibility enrollment, including reductions in provider reimbursement rates or benefits, or from implementing policies to control fraud and abuse. So I think if it was a case of fraud or of abuse, the MOE does not apply. Maybe I'm wrong on that, but if we do find, even if it's children, if they're enrolled fraudulently, I don't think MOE applies to them according to the quote.
So we'd be happy to go back to CMS, but the advice we've gotten, the guidance we've gotten is that anything that we do to constrain our eligibility policy is.
Ask them about fraud. If they were fraudulently enrolled, I think we're okay. The 30,000 people that we've identified and who have become, I guess, disenrolled, I'm gonna use that term. Does that be a good description? Disenrolled 30,000?
I'm sorry, she's confusing me with
Unenrolled?
980,000
Lost
adults.
coverage is probably the right term.
900,000 adults, I'm sorry.
There you go.
She was answering that last question. So
I'm sorry?
we were just trying to get you the number of adults is 900,000.
What's 8% of 900,000? It doesn't come
But
up to
keep
the...
in mind that not everybody's in the Workforce Commission data, so the match is not possible on everyone. If you recall the
Right.
study that LLA did, it was a subset of a subset of a subset, right? Because we had to
Okay.
get to numbers that had a match.
Okay, 30,000. What's the average cost per member per month?
No state general fund dollars, but in
So-
federal dollars.
So that's
what-
true. 98% of the folks who were disenrolled were expansion. So you're talking about, no state general fund.
6,000 per year?
It depends on the type of enrollment for expansion.
All right, well, I'm just going to use the 6,000. I think that's the average. If we apply 6,000 to the 30,000 people, 180 million in wasted dollars, I guess is the number I come up with.
So one thing that I would point out that is something that's still subject to discovery for us. So if you, and I'm sure you were paying attention to when we were doing this, but most of the people who received closure letters were people who did not respond to our request for information. So we don't know whether they continue to be eligible or not. We continue to monitor those counts. So when we originally announced the match, we thought that there were about 31,000 people who were going to lose coverage. By the time the month ended, that was 30,500. On a weekly basis, we're seeing about 800 people come back and demonstrate eligibility. I know that there are providers in this audience who've contacted me to say, I've seen, these children in my clinic today, and they're no longer eligible. Can you tell me what happened? And I go and look at it, and sure enough, they've been caught up in some of these wage checks. So
Yeah, I get
we
that.
believe that there's going to be a significant number of people who come back and who are able to demonstrate eligibility.
And the fact is, because we don't have, even if they're ineligible this month and we kick them off because they're truly ineligible, they can re-enroll next month if they become eligible again, because we don't have, there's no penalty for being improperly enrolled.
Nor is that possible based on the case law of the research that our legal team has done.
Point being, if I make too much this month, I can go and just decide to make less next month, become re-enrolled, and be safe for 3 months, more or less. Okay, are we doing anything with clawbacks or anything like that to try to, anybody who has been improperly enrolled, who we know is improperly enrolled, are we trying to recoup any of the 6,000 per year, per member, per month, whatever it might be?
So I'll let Steve speak to that, but again, unless there's a case of convicted fraud, we are not allowed to do that.
Okay, that's it. I'm good with the answer. That's fine. Where are we at? I know we suspended all checks of renewals. So when we got into the Deloitte, we just said if you're enrolled, we're going to just sort of roll you over and not go through a verification at all during the renewal process. Where are we at now on that? Are we actually checking people who are renewing?
So yes, so you're correct. When we rolled in the new system, we intentionally suspended renewals. every state that's gone through a systems deployment on this scale suspended renewals, many of them for a year. We did it for 8 months. We actually started resuming renewals just 2 months in, so 3 months in. So in the months of October and November, which were the training and the launch of the system, we did not do any renewals. In December, we started renewing. We started with newborns, pregnant women, and we did 1 month worth of adults in December.
What was the finding on the adults?
Overall, well, and I don't have it specific by adults, but in December of all the renewals we ran, 66% were renewed and 34% were closed.
Well, what does closed mean?
They lost coverage.
They lost, so we lost coverage at renewal. Is that going to be what we should anticipate in the future?
So that's not uncommon, and I'm happy to show you what the numbers look like for each of the subsequent months and the different populations that were enrolled. I believe that report was submitted to JLCB.
Okay, why don't you just kind of synopsize it for me? Should we expect to lose 1/3 at renewal every year?
So we lose a significant number of people at every month when we do renewals, and that's one of the points that we made when the 30,000 letters went out, is that this is not uncommon for us. We cover 1.7 million people. We mail a lot of letters every month, and there's a lot of turnover in our population. So yes, you're going to see the next month it was 67 renewed, 30 closed. The next month it was 76 renewed, 24
Jen, let me
closed.
ask you this. So we're saying, okay, I enrolled in January. Next January, I will be determined to be ineligible and I'll be disenrolled, right? At my renewal next January, right?
Unless you come up on the wage check in between.
Yeah, well, that's my point. I mean, if we're finding that 1/3 of the people get booted off at renewal at the 12-month mark, does that mean they were eligible at the 11-month mark? Probably not. The 10-month mark? Probably not. The 8th-month mark? Maybe. I mean,
So they may have aged out of the program. They may no longer be pregnant. They may have gotten married.
But it all didn't happen at a 12-month mark. So, I mean, the 11th and the 10th and the 9th become exceedingly important if we're finding 1/3 the population is not eligible to renew. Okay, I'm kind of made, that's not a question. I'm making too many statements. Okay,
But to your point, the renewals will be complete and completely caught up in June. We've renewed almost everything except for sort of smaller cases.
the kind of the holy trinity of eligibility is income, household size, and marital status. What I understand is we're beginning to work toward getting income pretty good, and we're still doing nothing to verify household or marital.
So we will start bringing in all of the tax data in May. We will begin to use in our business rules engine the total household income. There's a lot of logic that has to be developed for each one of those fields. The decision tree for household size and tax filer status is a lot more complicated than the income check. So we intentionally brought in the income first, and we're developing the specs for the other two to be brought in. So it'll be a phased approach.
You want to go through the list of things that we use attestation as the means of verification, please?
I do not have it committed to memory, but if you do, I'm happy to have you share it.
I'd seen my stack of papers. I don't want to find it. But right now, we just take somebody's word for about 10 or 12 things that if they say it's true, we assume it's true.
Yes, and some of those things we can independently verify, and some of them we can't. And so it's a combination.
All right, but okay. One of the things that came to my attention is that I think when we went down the trail of when we went into expansion, eligibility for food stamps was an automatic enrollment into expansion. Is that correct?
At that time, we sent out about 100,000 what we called canary yellow letters. There were 4 questions that they had to answer in addition to the questions that are on our application. And on the basis of those answers, I want to say about 30,000 people were enrolled from the SNAP program. That is not something that we continue to do on a routine basis.
Okay, at least that first 30,000.
Those have all been subject to renewal by now. So
undocumented aliens are eligible for food stamps. They're not eligible for Medicaid. I think that's what I've been told. Do you think some undocumented aliens managed to get in by the food stamp via?
I actually don't know the details on that, but I'll happy to find out for you.
And I don't know any aliens.
Immigrants, whatever. Okay, let's go back to The medical loss ratio, I think we finally done a medical loss ratio in the expansion population, which wasn't done with the MCOs, and the findings I'm understanding is we found that the MCOs owe the state $168 million for overbilling.
So there were, the medical loss ratio reports have been submitted by the plans. The part that determines how much they owe us is the audited MLRs. So our contracted accountants are reviewing those reports now. I think the fallish will know.
Be probably December.
Yeah, end of the year we'll know what that number is, but that is what they self-reported.
Okay, I've also noted, I think it looks like the FMAP rate, the federal is going to be a little higher this year than it was last year. Maybe it's gone up a couple percentage points. That should reduce our burden, the state's burden.
Yeah, I believe
48.
Chris said that was 48 million.
48 million. Go back to the medical loss ratio. Does 168 million owed by the MCOs to the state seem like a reasonable number?
Again,
I think
until-
that's a number I've heard.
Again, that's what was reported, but until it's validated, I don't know.
Okay, as we're going through the, obviously the idea that we've identified people, 1/3 the people renewing that we're not renewing, 30,000 people on the quarterly. I'm gonna let y'all finish your
Oh, I'm
conversation.
sorry, go ahead.
I'm looking at your Medicaid projection, and despite that, we're showing a growth in the total Medicaid rolls. They don't seem to match up. It seemed like if we're not renewing a third and we're removing 30,000, we ought to be going down rather than up.
Is that on the March report?
Yeah.
Yeah. So that was before we had the information on the 30,000, and so that March report didn't include that. But as you'll see, our projections through the end of the year went down to 472. So
Well,
that'll
I
catch
think
up.
in June you projected at 472, but it's
Yeah.
kind of peculiar. You're showing like a 30,000 reduction in expansion, but you're showing you're growing the non-expansion by 40,000 or 40-something thousand, which is way out of whack with the norm.
Right, yeah, so they're going to, it's based on really member months, and they're going to get kicked off for the last 3 months of the year. So they don't get automatically, it takes a while for it to catch up in the enrollment numbers.
Here's my point. From January to February, non-expansion went down by 1,000. From February to March, non-expansion went down by 4,000. But you're saying from March to June, we're expecting the expansion population to go up by about 39,000. It doesn't make sense. We're going down, 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 but your June projection shows us shooting through the ceiling again. What is the cause of that? I mean, it's your number.
Yeah, we'll have to look into it. Do you have, it doesn't, that's not what we have.
So the overall, you're actually anticipating by June we'll be 7,000 more enrollees, more than we are now. That's your report.
We'll look into it.
Representative Bacala, give him a second to grab the report so y'all can look at it and y'all can answer.
I'll give it to them if you want.
No, I mean, our,
The sheet we have is,
yeah, it shows that it goes down, so.
Representative Bacala, which report are you referring to, so we can,
Your March projection.
Talk about the non-expansion number?
Hold on.
Is it the non-expansion?
It's his report, March 2019. It's the last page with numbers on it. I'll
You're
give
talking
you
about the
mine.
non-expansion number.
Non-expansion's going up about 30-something thousand, I believe.
Yeah, that's the trends that we're seeing in that.
Well, it's not the trend for the first months of the year. You're showing a downgrade 1,000 a month, but all of a sudden now we're showing down,
We'll look
down,
into
grow
the,
by
specific
440,000.
eligibility categories and see what's driving that and get back to you.
Okay, a few cases. Let's jump over to the mental health side, the behavioral health. I've been made aware of certain cases. In one case, a counselor was paid $12,205.68. He showed he worked 245 hours, all on Christmas Day. So this counselor is saying he worked 245 hours in one day, Christmas Day. In another case, a counselor was paid $9,000 for working 179 hours on a New Year's Day. Another was paid for working 60 hours with a 13-year-old. There are other cases where 3-year-olds are diagnosed with Alzheimer's. We have a company in Shreveport who's knocking on doors and saying, will you sign up for mentoring, and then charging the state behavioral health rates to bring them to the bowling alley. I know all those have been referred to prosecution, so those are all good cases. How do we let that happen on the front end? Why don't we have things in place to make sure that these shysters aren't taking the state to the cleaners? There's dozens of these. I don't. Do we want to go deep?
Yeah, Representative Bacala, Steve Russo, Executive Counsel. From what I'm hearing from the back is that's going to be getting tightened up with the earlier conversation we had around the MPIs and the licensed mental health professionals and whatnot, and basically Senator Luno's bill.
I'll go back to Luno. I'll go back to my seatmate, Rick Edmonds. I mean, we're all bringing up this question is we have such, I know we're getting better, okay, but we were so loose in our regulation that we allowed any guy off the street to engage because we didn't have real licensure in mental health services, and so they would go into neighborhoods, $100 for anybody who'll sign up for our mentoring program, and then cut and pasting a diagnosis that was not by a licensed physician or clinician, and billing the state, I should say bilking the state out of millions. We also, I think, have a Medicaid provider who the state has paid millions of dollars to, whose children are enrolled in Medicaid. Those are the kind of just stories that just are sickening when we talk about how much there are in need. Okay, y'all can discuss that, or I'll move on from it. What happened recently, if you don't mind, because people have reached out to me, what has happened recently, if you can, the dental contract? We had a contract for a long time with one dental provider. We issued an RFP. We were on the verge of issuing another contract. I think the chosen provider didn't have the network they said they had, and y'all rejected it, and now we're back to zero, I guess. So
we'll be reissuing that RFP. There were a handful of provisions that when we re-examined them were not comparable with other states in the national market, so we're adjusting for that, and we'll be reissuing shortly.
Okay. This is a question from the audience. I'm getting a text. MMIS, I think we went from Deloitte, not Deloitte, we went from Molina to DXC, which DXC I think is the big hit for New Orleans, but maybe DXC has bought out Molina.
That's right.
And we're involved in a new computer program. Any
It's just a change of ownership.
Change of ownership, but not upgrading, because I think the computer systems there were aged.
It's the same vendor. Yep. I mean, it's a new name, but the in-state operations are the same. So
we're not looking to upgrade that system, and that system was Molina was the
we are, but not
intermediary.
Because of this change of ownership. That's just kind of a blip in the middle.
I'm talking about but the system. Are we upgrading
the provider enrollment piece is the first of that.
Well,
I think that's
eligibility was first.
Well, eligibility is outside of MMIS, but in MMIS provider enrollment, the one that we talked about, the centralized provider enrollment, that'll be the first one.
Okay, and what about the other component pieces? What are they?
So we're working on those. We're developing an RFP both for, probably next is going to be program integrity, but again, it depends on appropriations, so that's something that we're trying to budget for.
Okay. Okay, might want to ask more if I get another text on that one.
We're here.
Okay, I want to go to what is the source? When you look at the documents, your self-generated funds are going up by $165 million. Can you guys elaborate on what that is?
The main source is self-generated revenue from our public providers. We normally refer to them as intergovernmental transfers for the Managed Care Quality Program, the MCIP program.
You're talking about the income, the additional 165 in self-generated. Is that the MCO tax? Is that?
And that's the Managed Care Quality Program, the new program that we're implementing. That is the providers, the public providers providing the intergovernmental transfers.
So that's like the seed money kind of thing?
I don't think it's called seed. It's
I know
used
we
as
don't.
state
I'm
match.
just trying to get some common description. They're giving you money, you're parlaying into a federal match?
To our, yeah, it's the the state effort for that program.
All right, I'm not sure I understand it, but I won't delve into it any further. If I don't want to take up too much time. Right now you're asking for an extra $1 billion. Historically, last year you didn't spend $800 million, I think, of budget authority or something like that.
That was what Chris said, yeah, and part of that was reported in our little monthly report we did. I think we showed on average around 600, and then the remaining budget authority was used for our drug rebates that we need to draw down the federal portion for and then return to the federal government.
Okay, did we have $800 million we didn't spend last year? Current year?
It's
Budget authority, not.
It's not
I
money.
understand it's budget authority, but it's a beginning number that I think you build the future budget from. So if you,
And we have adjusted for that. You know, it's all based on enrollment. It's all based on who we think's in the program. It's also in Chris utilization, and Chris touched on it in his slide. I mean, when we build the budget, we build on a blended FMAP rate, but in reality, we have about six, seven different rates that, whether it's expansion, whether it's uncompensated care, whether it's Title 19, whether it's pregnant women, whether it's whatever, that we then reconcile the expenditures to. So we're always going to have a certain amount of excess budget authority. I mean, it's just.
you know, at this point in time, it seemed like we ought to start your budget at how much you expect to spend this year and start this year's budget, how much you expected or you spent last year, and then next year's budget sort of go from there. But we seem to always be, we're basing the future on false beginnings.
We do non-recur, and we have, and maybe not to the level of your liking, but we do have non-recurred our excess budget authority year after year. One of the different things for us is outside of the Medicaid program, I have 125 federal grants under all different federal rules. Some of them are block grants. They're all utilization driven. It's very hard to know who's going to be the next WIC recipient, who's going to get the next HIV treatment with Ryan White, you know, who's going to get the behavioral health services. And so it's just, you know, and I know, you know, some of the other agencies have had the same testimony. We also keep an excess budget authority on hand for disaster response. So there's reasons from an agency operational perspective. So we can talk about that.
I'm gonna kind of give over the mic, but I just want to mention one last thing. Medical vendor payments is under Schedule 09-306, so the programmatical area. It's a $13.3 billion is what HB 105, 13.3 billion in that program area of medical vendor payments. I'd kind of like, we don't know what that is. I mean, I don't know how much of that is MCO payments, how much is
Have a
nursing home
handout if you would
payments.
like to go
I
through it.
might want to see that, but I also might want to consider that we break up that one number into multiples so that we can track each of those perhaps a little bit better, so that perhaps anything over $1 billion we have its own category.
It's not 50-something pages like Chaz's, so I don't know if I can hold up, but we do have
Mr.
all
Chairman,
that
I'm just going to
detail.
relinquish the mic right now. I may have some more after a while, but I'm getting off.
Okay, I think they're going to pass out
I think I probably gave everybody a headache already.
it's close to 50 pages. Representative Bacala.
Be very, very brief, Mr. Chairman. I have a lot of questions. Let me just go down one path. I think the federal regulation, CMS has talked about they're going to eliminate supplemental payments at some point, defined time frame, correct?
I'm not aware where they're eliminating.
It's a moving target.
Oh, here, I can handle it.
Well, okay, well, we know that at least right now they're saying in 2026, I believe. Is that right? When does it go away, according to them?
Well, no, there was a timeline set by CMS, Representative Bacala, that if you had what is called pass-through payments, that you had to phase them out in regards to hospital pass-throughs and pass-throughs that related to physicians and nursing homes. You had 5 years, which you had to eliminate them. However, we don't believe we have pass-through payments, so we don't believe that would apply to us.
We don't think it's going to apply to us?
No, sir.
Okay, the UCC, I'll talk about this at another meeting. It seemed like it should have gone down. It really hasn't. We've gone from 1.1 billion now to 1.07 billion. I'd also like to talk about the 451 million we're talking about in additional payments to MCOs at some point in time.
Do you have a handout on that?
I do. I think I've got all this, but I'm just going to call it a day because we have places to be. So this will be another day. Thank you.